So I once had someone, not a scientist at all, give a talk to some students at Oxford. Maria Eitel was her name. And she said, find something that pisses you off and focus on that, because that will keep you going. You know, you're going to travel to India, or you're going to travel to parts of Africa, and you're coming from the UK or the US or Australia, across Europe, wherever it is. You can access, you've got to pay for it usually, but you can access a rabies vaccine or multiple doses of a rabies vaccine, and we give it to those people who are travelling to areas where there's a risk of rabies. But you get there, and those areas have people and kids, and those kids are at the greatest risk of rabies, but they don't get the same treatment that our kids, our neighbours' kids, do get. So that is very much what our rabies work is all about. Our rabies work is very much focused on addressing why does that happen. It is a scary disease. It's often associated with foaming at the mouth and things of that nature, and especially in dogs, and that's a bit daunting. But the other scary bit is once someone is showing symptoms, they are dead.
Hello and welcome to Meet the Medicine Makers. I'm Menashe, an early career drug discovery scientist, and this podcast shares real stories from the people behind how medicines are made, from early research all the way through real-world impact. Today, I'm joined by Dr. Adam Ritchie, senior vaccinologist at the Jenner Institute in Oxford. His work focuses on the translation of academic research into real-world impact through the efficient development, manufacture, and clinical testing of vaccine candidates, including, recently, rabies vaccine research. In this episode, we'll explore what it really takes to develop vaccines, why rabies remains such a significant global health challenge despite being preventable, and how this work fits into the broader process of turning scientific research into real-world medicines. Adam, thank you so much for joining me.
Thanks for having me, Menashe.
Well, to start, how did you first find your way into this area of research?
So I guess I was interested a long time ago, back in Australia when I was a kid, in digging up dinosaurs. So headed me towards biology, as it were. When I was studying as an undergraduate, I didn't really see what I was actually going to do with that as a career. So I was quite into evolution and concepts around that. So I got into studying some microbiology and some immunology, became interested in how viruses evolve in interaction with us, and sort of got into a big interest in how hosts and pathogens interact. And then I went on to do my PhD in that area. And then I came to Oxford in 2005 as a postdoctoral researcher, did that for a little while. I started in what I'd call basic disease research, so not really developing vaccines or medicines, but I slowly moved more clinically over time. So I sort of started off doing some work looking at protecting the blood supply from prion diseases. So after the mad cow disease / variant CJD issues here in the UK, and then moved into studies of HIV, including why some people may or may not be protected or might be lower risk of infection, and also what happens after people get infected and how the immune system interacts with that. I then transitioned, took a slight unexpected move in that I got involved with a new department at the University of Oxford in social sciences, which became the Blavatnik School of Government. Spent a little bit less than a decade there developing the Masters of Public Policy program and helping found the school. And in about 2017, I decided I wanted to go back to scientific research. And so I then joined the Jenner to work on a program looking at rabies vaccines and also stability of vaccines.
And for anyone who might not be familiar, could you explain what your role at the Jenner Institute involves?
So I think it involves everything. And maybe that's one of the benefits of being in an academic setting. And I sometimes, when I talk to people early in their career who are interested in this field, I say often working in a university can be a good starting point, rather than going directly to industry. And the reason for that is I've obviously done a PhD and been a researcher, so I have a lot of research experience. So a lot of the preclinical work, animal-related work that is a big part of preclinical. But then you get exposed to working on designing, executing, and safely delivering clinical trials. can't do a clinical trial without a drug. So I've been quite fortunate to get quite deeply involved in manufacturing. I don't do the manufacturing myself, but I work very closely with those who do here at Oxford. We have our own little facility here, the Clinical Biomanufacturing Facility, that makes medical grade, or what's called GMP, good manufacturing practice, which is the regulations around that area. So they make compliant medicine that we can use in clinical trials, basically. So I've got quite a broad experience, and I continue to do that. I sort of enjoy the challenge. You might see it as a jack of all trades, master of none sort of approach. When I sometimes talk to colleagues in industry, you often see they're specialized in certain areas, which is a part of my job. I mean, I have recently sat through a thing where they were talking about the different roles in some industrial settings, and there were 5 or 6 different jobs, and I sat there going, these are all my job, sort of thing. Where am I? I don't get to hand these things off to other people. And so I think even if you are going to specialize, which a lot of people of course do, and that's fine. I just like the challenge of never specializing. But even if you're going to, speaking the language, having an understanding of what's happening in the other spaces that you interact with, I think is very valuable. It makes you more effective in what you do when you specialize.
I mean, you've highlighted a lot of the benefits of working in an academic setting. It seems like you do many, many, many roles. Are there any challenges or drawbacks compared to, say, working in an industry setting?
Yeah, you have to do many, many, many roles, sort of thing. So, it can sometimes feel like you know enough about this thing to get the next bit done, So, I would love to have a deeper understanding of GMP, for instance, so that I could plan things slightly differently or perhaps more effectively. But that's the balance, it's maybe that's the part of me that's a bit of a control freak. I work with lots of colleagues who are specialized in that area, and they can do that bit, sort of thing. But it is a case of needing to speak lots of languages, sort of almost like sitting like a spider at the center of a web, sort of thing, where you've got inputs coming from lots of directions, and you're trying to make sure that we're manufacturing on a time scale that for the clinical trial we're setting up is going to work, because all those, there are different specialists working in those areas with us, but I'm the one who's got to talk across them and understand that the risks of the project and how everything's going to line up. So that's a challenge. Academia is sort of for those of us who don't use their weekends appropriately sometimes. My wife is an academic as well, so we understand each other from that perspective. But that's, if you enjoy that and have that passion, then that's all sort of part of the game.
And I mean, I assume you need good time management skills in order to sort of do well in your role. Are there any things else that you would need, or would you say you don't actually?
Well, I'm sometimes self-critical on those things. I guess someone from outside would say I do have time management skills. Maybe I sometimes look at my diary and go, I'm not managing that as well as I could. But you're right, it is a very important one. Obviously, lots of things moving in all sorts of directions. Sometimes people talk about this thing where you've got to learn to say no. So, I had an interesting thing over the weekend, asked to review a journal article that I was quite interested in and quite inclined to do, but actually I've got a couple of big deadlines coming up, so I couldn't commit to that, to the standard and on the timelines that I would need to commit to it on. So I had to say no, and you feel a moment of guilt about that, because, I had my paper published last week and 6 people reviewed that, and it is part of the game. We review each other's papers, right? But you can't do every one that comes across your desk. You can't do every project that comes across your desk. It is something maybe sometimes as you say, I do rabies, but I do a bunch of other things. And if you stretch yourself too thin, you can get to the point where you're not doing as well as maybe you should be doing on your projects. Eye for detail, I think, is a pretty important one. But I think the biggest thing is sort of a combination of critical thinking, that thing we try and encourage in the students we teach. There are limitations to how effective you are if you just follow what was done last time. You need to be able to look and see what if we develop it this slightly different way, or what if we go to the regulator and ask this question. I actually have some projects coming up which are focused on encouraging that sort of thing. So, that's sort of critical thinking. And sometimes people say self-starter. I think just being able to do things independently, not getting sort of stuck it like a deer in headlights going, there's so many rules and regulations, I don't know what to do. They're all things you can work through, and they're there for a reason, but they're there for your interpretation, and think about risk and uncertainty and, what are the innovative ways through a problem? If we don't have people who think that way or do things that way, we get no new medicines, no new processes. It's all part of this game.
You mentioned your paper coming out. I think one of the ways I found you was through some of your work that's most recent. A lot of your work has focused around the rabies vaccine. What first drew you into working on rabies specifically? And could you tell us more about your research, your paper, the things that have come out from that?
Sure. So I once had someone, not a scientist at all, give a talk to some students at Oxford. Maria Eitel was her name. And she said, find something that pisses you off and focus on that, because that will keep you going when the hours are long and something gets in your way. And I thought that was an interesting take on things. So to me, I'd not, 10 years ago, I hadn't worked on rabies and it wasn't a focus of mine. It is part of my career that I've moved disease to disease, which I've enjoyed because I'm curious and I like learning about new diseases. But something that was pretty transparent pretty fast was there are vaccines that work. If, a few years ago, a neighbour's kids were, going on a gap year pre-pandemic, and you're going to travel to India or you're going to travel to parts of Africa and you're coming from the UK or the US or Australia, where across Europe, wherever it is, you can access, you've got to pay for it usually, but you can access a rabies vaccine or multiple doses of a rabies vaccine, and we give it to those people who are traveling to areas where there's a risk of rabies. But you get there and those areas have people and kids, and those kids are at the greatest risk of rabies, but they don't get the same treatment that our kids, our neighbours' kids, do get. And so that sort of jumped out as a fairly serious inequality to me. And, I'm not naive. The world is an inherently unequal place, but you can get annoyed about something like that, as it were. You can go, I'd like to try and address this problem. So that is very much what our rabies work is all about. Our rabies work is very much focused on addressing why does that happen. And it's a combination of science and sort of, I guess, policy-focused work and health economics. Last year, we published a paper challenging the idea that vaccinating kids against rabies before they're exposed to it is cost-effective. So that's sort of been a central part of how rabies has been dealt with over the last decade or two. It was some sort of economic modelling studies that said, if we vaccinate kids against rabies, it costs a fair bit of money. What economic benefit do we get at the end, sort of thing? And it sounds like a harsh way, but this is how health economists think, and we do value years of life, and there are competing interests on money. So you can't just go, let's just do it. But to us, that's always been a little bit surprising. Now, a lot of the field is sort of rabies focused, where I guess what we are is we're vaccinologists who come in looking at an issue with a slightly different lens. And so, for instance, rabies is a scary disease, right? Basically,
I mean, yeah, I was going to ask, could you give us a background of what is rabies? Why is it such an important disease to work on? Like for someone who might not be familiar with.
So rabies is a zoonotic disease.
What does zoonotic mean?
Zoonotic, it comes from animals, right, which is where lots of diseases come from, at least originally. But this is one where that's the way it spreads regularly. It doesn't really spread human to human, and basically we don't see it spreading human to human because it's basically spread by bites. So it's most commonly spread by dogs biting people. In certain parts of the world, it's spread by bats biting people, and there is a element of exposure through other animals, cats, monkeys. Of course, I've read lots of rabies research, and there's interesting papers looking at potential exposures, jaguars, and all sorts of things. I do think if you've been bitten by a jaguar, you may have other issues than rabies. But anyway, so it's a bit of it is a scary disease, and one of the reasons it's a scary disease is, it brings up these images of sort of violence and violent animals. It is a disease that makes mammals aggressive, generally speaking. So it's often associated with foaming at the mouth and things of that nature, and especially in dogs, and that's a bit daunting. But the other scary bit is once someone is showing symptoms, they are dead. They just It just hasn't happened yet. There's nothing is absolute, but that gets pretty close. There's one or two edge cases where people who have started showing symptoms have survived, but they've not survived in the greatest health where that has happened, and it's phenomenally rare. Like globally accountable number of cases, one most famous one, maybe two. So it's very scary from that perspective. So there's a scariness to it, and it is treatable before symptoms effectively. So you get bitten by a dog who might have rabies, and if you get treated within 24 hours and then get treated, there's a few different schedules, but basically you need to come in for at least 3 visits, maybe day 0, day 3, day 7, or day 0, 3, 21, something of that nature. Usually you're just getting vaccines, so exactly the same vaccines we would want to vaccinate kids with before exposure, and you might get immunoglobulins as well if you've been severely exposed. So it just depends on the situation. But that's reasonably expensive. And when we go back to the economics and vaccines question, you have the issue that in the older economic modeling, what is basically being modeled is if you vaccinate lots of kids, do you save money later on by not needing to give them immunoglobulins when they're bitten, or not having to give as much vaccine later on? And so it can only be cost effective where the cost of pre-vaccination makes up for savings with post-exposure treatment. And that's unusual. You'd have to have a lot of kids being treated for that to add up economically. But because it's scary, there are certain types of trials you can't do. I can't run a trial where I vaccinate a bunch of kids and then get dogs to bite them, right? And then see if they get rabies. Because the second they show symptoms, they're going to die. So if we have a clinical trial where we're looking at this and someone gets bitten, you treat them. Right? So you can never answer the question in an ethical way, is how effective is giving someone vaccines before they ever encounter rabies? It's just a question you can't answer in the classic sorts of ways that we would for other vaccines. And to be conservative, people have gone, well, it doesn't, let's assume it doesn't do anything. No one gets saved by that alone. That's often been the approach, which we think is wrong. And why do we think it's wrong? Like, you're doing something quantitative, you're building a mathematical model, you don't have the evidence to go, it's 30%, 90%, 50% effective, so you just go, we're not going to put it in. But vaccinating Western travelers is because we know it does something, right? Right, we know it does something. Even if it just gave you more time to get to a treatment center, that is something. But even that is, to us, unrealistic. And there's animal studies and there's a few real world experiments which suggest it's quite effective. So in the Peruvian Amazon 10 plus years ago now, for a few years, they vaccinated kids because bat bites are harder to notice. They're not reported in the same way a dog bite is. And when they did that, kids stopped getting rabies. But the program was expensive, so they stopped doing it. And rabies last year, 2 cases came back in kids who were too young to have been vaccinated originally. But their brothers and sisters, older siblings, have not had it for quite a few years there. So it tells us it does something because nothing else changed, but hard to put a number on. So our modeling paper last year said, we're not going to ask the question, is it cost effective? We're going to ask, under what circumstances would it become cost effective? So we basically modeled what happens if you give kids a vaccine and over 15 years it's 80% protective, 50%, 30%, 10%, and that gave us information on, basically said if it was 30% effective over 15 years, which I think it definitely would be personally, but I can't prove it, right? And that's important. Then it becomes pretty cost effective pretty fast in a lot of places. Now, it wouldn't be in the UK because there's no rabies. Right, so you save 0 people and you just spend the money giving it to people, right? So, but in places where there is rabies at a reasonable rate, it becomes pretty effective. And there's billions of people who live in countries where that would be the case. So that's that. And the vaccine we're developing, so that's the economic side of things. The vaccine we're developing is designed to address the costs of vaccinating kids. So vaccinating kids, it's multi-dose, 2 or 3 doses now. It used to be 3+, but now it's down to 2. Of the current vaccines. Our vaccine's designed to be single dose, and the hope is, and it's also cheaper to manufacture than current vaccines. So, it's built on a similar platform to the Oxford AstraZeneca COVID vaccine. We were involved in working out how to manufacture that. Cost of goods for that's about 20 euro cents a dose. So then you've got to get it in vials and get it to people. So it might be $1 or $2 to vaccinate a kid with our vaccine at scale. That's very different to the $80+ it costs to vaccinate kids in the Peruvian Amazon 10 years ago. So all these things, it's basically trying to use science to address what's an economic problem. And I guess, your career goes in different directions, and the time I spent with talking with policymakers and students who wanted to be policymakers sort of made me more interested in that sort of thing.
Is there anything that people underestimate? Like, I didn't think I fully appreciated how scary rabies was, but is there any other areas of sort of solving this problem that people don't fully understand or may not fully understand?
Well, there's uncertainty around everything in the world, but there's plenty of uncertainty around rabies, like how effective are vaccines, very hard to measure, so we remain uncertain. Other stuff's quite uncertain, like how much rabies is there?
How much rabies is there?
How much rabies is there? So central estimate from the best study on this about 10 years ago is in the ballpark of 60,000 deaths a year globally, which puts it at the higher end of deaths from neglected tropical diseases. But it's not well reported, right? That again is modeling. You get different numbers depending on different places. There's an Indian study called the Million Deaths study, which is quite interesting. It's not about rabies, but there's been some work on rabies within it. And that sort of puts the numbers of deaths of rabies into the ballpark that would lead to 60,000 globally. So I think it's a fairly reasonable estimate. If you do go on clearly identified reported cases of rabies globally, it's much lower because most cases are not clearly reported. Like who's going to run the diagnostics to go, this kid in a rural area 4 hours travel away from any major medical center died of rabies or something else. It's just it's a data gap, and that exists for a lot of diseases and a lot of things in life, but it is something that's uncertain. So sometimes we like certainty. It is a human nature to X causes Y with 100% certainty, and that's all fine. But it's not reality, and people sometimes underestimate that or don't think about what variability and uncertainty actually means in the real world.
And I mean, we've mentioned the fact that rabies is preventable. Cases in the UK, as you said, are basically zero. So a lot of these rabies deaths happen in lower income countries, and we've mentioned children. How does that shape the way you think about vaccine access and sort of global health and sort of these disparities?
Yeah, in a very big way. I mean, the Jenner Institute is quite focused on diseases of that part of the world. It is an area where Western commercial interest is very different. It's not a disease that affects people like me particularly, who have good salaries and make plenty of money. And, if you can come up with a treatment for a cancer that I might get, you can charge a lot of money for it, right? We're coming up for something that is for those in the world who do not have a lot of resources. Charging a lot of money for it is not in your future. So that commercial interaction is different. Hence, it massively influences the way we think about this, right? I'm not thinking about a vaccine for Western travelers. Like that exists. The market's there. The companies make enough money off the drugs, off the vaccines they sell into that market. I'm not trying to fight into that market. I am trying to produce something where there are companies that specialize in sort of very high volume, low profit margin products, like a lot of the big Indian manufacturers, Serum Institute of India, which was involved in the COVID vaccine, but is also making the malaria vaccine that's being rolled out. Make a lot of it, sell it to governments or sell it through payment mechanisms of places like Gavi. And, those companies do exist, but it's a much smaller pool than things. So that's, I think, one of the reasons why you see this sort of research, especially in academic settings. Of course, the driver for it is a little bit different, but it does, you do, if you want to have that real world impact, you mentioned at the start, that's one of the things I care about. I really do. I get a bit frustrated by academic research, which doesn't really think about the real world or go anywhere. Its basic research is very important and valuable, and it leads to a lot of things. But sometimes you see people going, I'm going to develop this vaccine or treatment or something, but there's no pathway beyond I'm going to do the interesting stuff in the lab and see something. A big part of what we try and do, and the Jenna has a very good track record, is develop our vaccines in a way that allows us to transfer them. So it's called tech transfer to a manufacturing facility, develop a process that can tech transfer. 2017 to 2019, we spent a lot of time thinking about, because the rabies vaccine for us is an economic problem. For it to be a solution, it needs to address that problem, which means the manufacturing process has to be scalable, right? And the processes we had up to that point were not very well scalable. They had process elements where to double it, you had to double the amount of work, right? And if you want to make 100, 1,000, 1,000,000 times what you do in the lab, having to have that many more centrifuges is just unrealistic, right? So we spent those years going, we need a process that is scalable and that you can tech transfer to a manufacturer anywhere in the world. And I would love to transfer it to a manufacturer in Africa. That would be my dream. And we, post-pandemic, some of that capacity is improving, which I think is great. One of the few times I've considered leaving academia, but I didn't, was to get involved in that issue, because that pisses me off, right? So I did consider it at one point quite seriously, but decided my impact was better where I was. But I think that's the practical, that's the translation side of things. You can have the best vaccine in the world, but if it can't be made, it might as well not exist. You've got to have a way of getting across that. And there's huge valleys of death in drug development. The first one is from the preclinical to phase 1 clinical sort of thing, that first manufacturing time. And the other one is up getting closer to licensure, sort of often it's for phase 3 manufacture. Like, can you have the at-scale process definable and executable consistently in a way that will allow you to license and make lots of the product? And we unusually, for academics, think about not just that first valley, but sometimes the second valley as well. And we were definitely thinking about that with rabies when we were developing our stuff last decade. And it was that work that actually led to the process that made billions and billions of doses of the COVID vaccine that came out of Oxford.
Yeah, and I think I was going to transition into this. So the average person in the UK might not know a lot about rabies vaccine, but they will probably know a lot about the COVID vaccine. And you were also involved in vaccine manufacturing efforts for that, which is also a virus, but different. What did that period teach you about the realities of developing vaccines at scale, especially given that you contrasted the challenges of trying to do that for something like rabies?
Yeah, so serendipity, timing, all these things are important. I sometimes say you've got to have 3 things to really have an impact. So you've got to be good, right? And lots of us are good. You've got to work hard. There's no point being clever if you don't put in the effort. But also you've got to be lucky. And you can have the first 2 and never get the third, right? And that's just reality. That's uncertainty in life, okay? And, it just, the timing for us just worked out. Or maybe I'd almost say the timing for the world worked out in that it was late 2019, a postdoc working with us, so Karina Joe, she brought us some results before Christmas in 2019 and had found a way to increase productivity from our manufacturing process, from what we would call, I'll try and avoid too much jargon, but from the upstream part of the process where you actually make the vaccine the first time before you purify it in downstream. She had gotten productivity to increase 30-fold. Right, so if you were making 1,000 doses, you can now make 30,000 doses, right? That's a big step change. And we, Karina's excellent, and we had hired her for a reason, but we were skeptical, so we made her repeat that in early 2020. And we were like, well, this is going to make a big difference to the rabies program. Around that same time, the sequence in January 2020 of the virus from Wuhan was released, and our colleagues at the Jenner, who are always working on these things, always looking at what's emerging, the disease X concept. And so they made the first version of that vaccine. We, 6 of us, got together actually in this office that I'm speaking to you from in early 2020 and said, let's do this thing, and different responsibilities fell in different places. And so Sandy Douglas, my boss, who's a clinician, professor here at Oxford, and I and Karina led the program to work out, hey, if this vaccine works, we're going to need a lot of doses very fast. How the hell are we going to get that? And we went, well, 30-fold productivity increase is a good place to start. And we developed that further in those early months of 2020. We started having it made at multiple sites around the world, and that was before AstraZeneca got involved, which was in May 2020. So we then worked very closely with them to transfer the process to them, and it's the proudest achievement of my career is not that the vaccine worked, but that something we had wanted to do, which is called distributed manufacturing, is what happened. So very obvious that vaccine nationalism was going to be a thing. How do you counteract that? I don't control governments. I did once or twice have people attempt to get me to control governments, but I said that is not my power. The best way to combat it is to not have it centralized. So if it's being made in America and Europe only, America and Europe only will get it, and then it will be benevolence to give it to others, right, with the best will in the world. But what if you just give it to everyone? Like, what if we just make it in as many places as possible? So before AstraZeneca joined, we had started the process of making it in India, China, the EU, and the UK. And AstraZeneca joined, and to their great credit, they continued that principle and made it in a bunch of countries in, Asia, Latin America, everywhere. There wasn't somewhere in Africa that could make the product at scale, sort of thing. That I'd love to see change. But to me, that's the proudest thing. Because, when India had a horrible second wave and they put in export controls, other countries who were manufacturing were able to fill the gaps globally. And so our vaccine, in analysis of the first year, was estimated to have saved the most lives, even though the Pfizer vaccine was manufactured at about the same scale. So we were the two big ones, Oxford, AstraZeneca, and Pfizer. But the reason ours might have had such a big impact is because it went to some of the places where it was needed more. Some of the Pfizer doses at that point were already going to 30-year-olds getting their second, third dose, where first dose to healthcare workers in Ghana are more valuable in saving a life than a second or third dose to a healthy 30-year-old in America or Europe. So that was a great achievement, and it was done at not-for-profit by AstraZeneca, which was great. They never got the credit for that. They should have. And never have worked for them, sort of thing. I just sat near them and saw they put in the effort, as it were. They could have made a lot more money if they had done it in the way some other companies did and charged a lot more for it, but would have gone to fewer places. So that was, that's was the big thing. And that's like, I don't want a pandemic. It's not that fun. No one thought it was fun. Sort of thing. It was a lot of hard work, but you sort of prepare for the worst, and it's part of what we do, and we pivot when it was needed. We had to do it very difficult. But in 2022, there was an Ebola outbreak in Uganda, and the World Health Organization suddenly wanted vaccine. Now, that vaccine ultimately didn't control the outbreak. It was controlled through healthcare intervention and distancing and those sorts of approaches. But we got, working with the Serum Institute of India, we got 80,000 doses in the country, I think 81 days after the request came, where it had never been made at scale before. So, that's the pivot and the ability to respond quickly. I found that, and I'm not the only one, I found that period very difficult personally, like a PTSD type response, just because we hadn't quite emotionally processed the difficult. There is something about working more than 100 hours a week, months on end. I discovered you can have 4 or 5 meals a day when you're working those long hours, and to the detriment of my waistline, which I still am struggling to get back under control. But it's a price you sort of pay quite willingly, because it's the moment when it's needed.
And I mean, even though this is not your area of research, there's obviously been recent news about emerging viruses like hantavirus, and you mentioned nobody wants a pandemic. A lot of people are still recovering from the effects of COVID. But how do people working in your area think about emerging infectious diseases threats, like emerging infectious disease threats more broadly?
Yeah, so that's a big question. Different people think about it in different ways, but there are teams, which I've got to say, not that actively involved in. I occasionally get dragged in when there's a reason, but we're all colleagues, and we interact when we need to. I go to them for stuff all the time around immunology and helping with this sort of animal study or something like that. But there are people at Oxford, there are people all over the world where this is basically the focus of what they do. So if I think about someone like Professor Theresa Lamb, who I've been friends with for many, many years, and we had to work almost too closely together. We did have to work very closely together, a lot of us, during the pandemic. And the Ebola vaccine was hers as well when that came up in 2022. But this is the big focus of her work, and the work of other people as well, which is, you might be developing vaccines against things like Marburg or Ebola, things that are known epidemic or pandemic threats. But also part of what you're doing is you're looking for any bad news, right? And bad news comes along once in a while, and you might start preparing a vaccine for that. And what you hope is that you've wasted a weekend. You hope that you've maybe made something in the lab that will never go into a person because this scary news story, this danger signal that's come about, or this cruise ship that's had a few cases doesn't seed something bigger. But, and this was the conversation we had around Ebola, Sandy, Douglas and I, which was, we're not very enthusiastic about doing this. We think this is very likely to be gotten under control without a vaccine. But if it gets out of control, the vaccine will be very needed. And that just answered the question of, are we going to do this thing? Are we going to put down, because it meant putting down the rabies research for a month or two, just to support that sort of thing. And we went, well, that doesn't help our rabies program, but there's a risk here. It will probably never pay out, but that's, if there's a 5% risk and you've got to put a month or two into it, because if that risk materializes, the cost of what happens is catastrophic, then that's what you do. So that's the way, at least locally, we respond. I don't know how every other research group in the world or research teams or collaborators in the world respond to this sort of thing, but that's certainly how we basically do it.
And as we come to sort of the end of this episode, for someone early in their career who's interested in vaccine research or global health, what advice would you give them about entering this space?
Yeah, I think sort of be open and not too fixed on what you think you want to do. I've got the biases because it's how I've done things. And so, of course, everyone thinks the way they did things was the clever way. But, lots of early career jobs, which are like clinical trial assistants or junior project managers, like it may not sound super glamorous at the start sort of thing, but that's how, a clinical trial assistant learns how all different elements of a trial runs, learns about looking after investigational medicinal products, which are developing drugs, and then can specialize in all sorts of areas. I've seen people go from that into project management and then getting involved in the whole development program. I've seen people come in from a finance background and go into, clinical trials, careers. Maybe I don't need to tell people starting now, right? This was something that shifted in my generation quite a lot. Careers are not as linear as they were for my parents, or I guess your grandparents. So yeah, be open to sort of just taking on roles, trying stuff, and yeah, I you might be in a position of any job's a good job right at the start sort of thing. So maybe you don't have the choice to do a diverse role like I'm suggesting, just get your foot in the door. But if you're in a singular team and you're at a big company, you can look at what the other teams are doing. You can talk to them and learn to speak across teams. And then after that, it's just sort of cliched stuff. But some of it is good and real. I'm not the only one, but about the worst thing you can do is speak down to the lowest people in your organization. I've encountered it a few times, people who will speak very respectfully to me or senior colleagues, but we then find out they've been rude to junior researchers, or the worst thing you can possibly do is be rude to the cleaners, sort of thing. I always think it's a good thing if you are on a named basis with the people who clean your space and you're on a shared journey together, because nothing works without everyone, sort of thing. So don't get airs about yourself. But as I say, that's a bit of a classic cliche, but it is true. It is true.
And where can people go to find out more about you and your work and the things that you're doing and stay updated?
Well, we've got a Sandy Douglas Lab Group LinkedIn where we put things, and as an academic, our main currency is our papers, sort of thing. So the health economics paper last year and the clinical trial from Tanzania that was published last week in Lancet ID, or Lancet Infectious Diseases. That's the sort of place, if you like reading those academic things, you can, if you want to hear more about the COVID work, you can sort of just Google me and COVID, and there's a few videos and things out there about that sort of thing. Policy in a pandemic videos, and I spoke at iGEM last year, 5 years after the pandemic, and that was if you're interested in career advice and stuff like that, that's what that one was about. But yeah, that's I don't do that much social media. I'm not on Instagram or TikTok or anything like that. I am on Twitter, but I don't touch it. It's gone a bit ugly, Twitter, these days, or whatever it's now called, X. But yeah.
Oh, thank you. And before we finish, I like to remember that people just aren't their work. It seems like you've done so much work over the years. So is there anything you like to do outside of work or what you do professionally?
Yeah. I many, many years ago, was a football referee back in Australia, and there was a young lady who played on one of the teams who I sort of thought seemed interesting, and she apparently thought I seemed interesting. So we moved to the UK together sometime later and started a family and got married and all those sorts of things. I love football. I coach girls football. I've done it for about a decade. It's the thing that keeps me grounded in this universe. So we train, we play matches, we win with grace, we lose often, but we lose and we learn. And then beyond that, I'm just, classic stereotypically scientific nerd, which means I like nerdy movies and nerdy card games and bad science fiction. So,
Adam, thank you so much. This has been a really, really interesting conversation, and I really appreciate you taking the time to share your many, many years of experience and perspective.
That's great. Very nice to speak to you, Minash.
And thank you for listening to Meet the Medicine Makers. This podcast explores the people behind how medicines are made, from early research through to real-world impact. If you found this episode useful, feel free to share it with someone who might benefit, and you can find out more about Adam and his work, including his papers, in the description. Thank you.